Well, hello everyone, and thank you so much for joining us. The Southeast Mental Health Technology Transfer Center is pleased to present today's webinar event, the sixth and final session in our six-part series, Keeping It Practical, Core Skills from Evidence-Based Practices. Today's session is titled Takeaway Tools, Unifying Themes Across Evidence-Based Practices. My name is Emily Moore, and I will be moderating today's event. Before beginning, I would like to take a quick moment to describe our center and what we do, and then I'm going to hand it over to Dr. Benjamin Druss, who is going to introduce today's speaker. Here is a brief disclaimer from us and our funder at the Substance Abuse and Mental Health Services Administration, or SAMHSA. And just a brief reminder that the MHTTC network uses affirming, respectful, and recovery-oriented language in all of our activities. The Southeast Mental Health Technology Transfer Center is located in Atlanta, Georgia at Emory University's Rollins School of Public Health. We are proud to serve the 8 states in HHS Region 4. Our expertise in public health programs, systems, research, and evaluation provide a unique lens through which we can address mental health priorities. The goal of the Southeast MHTTC is to accelerate the adoption of evidence-based mental health programs by providing training and technical assistance to Region 4. We use a public health approach to build leadership capacity and to provide mental health trainings and resources to providers, agencies, and communities across the Southeast. We encourage you to visit our website to learn more about our center and our upcoming events. A few important notes before today's event. This event is being recorded and will be posted on our website for on-demand viewing, typically within about 72 hours. We also encourage you to share your thoughts using the chat feature at the bottom of your screen, but please remember to select chat with all attendees if you'd like to share your comments with everyone. We will devote some time at the end of our presentation to answer questions. Please submit your question using the Q&A feature at the bottom of your screen. And finally, for anyone who is interested, you can download a certificate of attendance upon completion of our evaluation surveys. And with that, I'm going to hand it over to Dr. Ben Druss, and he will introduce today's speaker.
Thanks so much, Emily. So I'm delighted to introduce Michelle Salyers, who is a professor of psychology at Indiana University, Purdue University, Indianapolis, IUPUI. She directs the ACT Center of Indiana, a collaboration of academic and community partners, including researchers, administrators, clinicians, consumers, and family members who share an interest in recovery-oriented, evidence-based practices. The overarching goal of her work is to help adults with severe mental illness live meaningful lives in the community. Her research addresses both consumers of mental health services and the providers of those services. She's increasingly targeting the interaction of consumers and providers, looking for the best ways to support relationships that promote recovery and well-being. Her current work involves developing effective ways to reduce staff burnout and to increase shared decision-making in mental health care. And with that, I will turn it over to you, Michelle. So nice to have you here.
Thank you. It's great to be back. Let's see. Share my screen here. And there we go. Okay. Well, welcome to new people and welcome back for those who've been with us for a while. It would be great in chat if you want to let us know where you're tuning in from. I love to see where people are. I am tuning in from not so sunny Florida, but it's humid, so it's a little shiny today. So today we're going to do our kind of wrap up session for the last part of our series together. Okay, slides, okay. All right, so our plan for today, Oh, this is great to see where everyone's lots of different places all over. Well, welcome. So today I want to talk a little bit about where we've been as part of this series, talk a little bit about evidence-based practices and the ones specifically that we covered in our series. And then we'll focus more of our time on the core themes that unite them. So what is consistent across those evidence-based practices that you can be doing with the people you work with. And then I want to spend some time on practical change strategies. So before this session, when you registered, we got several questions about how to do this work. And so I wanted to spend some time on change strategies, both for ourselves, if we're trying to do something new in our practices, and the people we work with. And then end a little bit on what's next after this series. So just as a reminder, our goal was to review core aspects of several evidence-based practices for people with severe mental illness, so psychiatric rehabilitation focus, and bring in different leaders, researchers, consultants who work with those practices, and really make it practical. So what can you do now to make a difference? And just as a reminder, when we talk about evidence-based practices, the practices themselves are specific practices that have shown to be effective in rigorous research in a variety of settings. But to do evidence-based practice, you're really integrating what the research shows us, what works well, your own clinical expertise, and then the person you're working with, the client or consumer or patient, that person's individual identity, their preferences and values. And so it's really not just, here's a model, you need to follow it step by step, but you need to integrate what you know how to do well and what the person you're working with wants and needs. And the ones that we covered in our series, as a quick reminder, we went over illness management and recovery, a lot about goal setting and training people to take more control, collaborative decision making. We talked about assertive community treatment, and some people call it ACT, like myself, and some people call it ACT. In different parts of the country, you'll hear different labels, but assertive community treatment and supportive housing, supported employment. And 2 weeks ago, our last session on a specific practice was integrated dual disorders treatment, or how do we work with substance use problems in people with severe mental illness. So I wanted to take a moment here to do just a quick poll to see which of these sessions you may have attended. So I think Stephanie or Emily's going to post. Okay, so if you could, says check all that apply. I'm not sure if we can do that, but if you could take a moment and check all that apply so I can see which ones you may have attended.
Hey, Michelle, I see in the chat
Yeah.
that some folks can only check one, so it might be a good idea to have people put in chat which ones they attended. They cannot
Okay.
check more than one.
Thank you. That is a good idea. All right. Yeah, I could see on the poll, it does say single choice. First two. Yeah, just put in the chat what you might have done before. Okay, so some of the individual ones. Attended all of them. Julie, thank you for your commitment. All right. Well, as you're typing into chat, I'll just do a little bit more on what we're going to do today. I'll do a recap, a brief recap of them. Thank you, Julie, for that. Deborah's been to 3. Great. So 2, 3, and 5, Dennis, nice. So I'll do just a brief recap of those and then really jump into some of the unifying themes and then how we can make changes to do them. Great. So the first session, illness management and recovery, and that was a session that I did. And IMR is really a structured curriculum that empowers people to learn the information and skills they need to really take more control over their illness and to make progress towards their own personal recovery goals. And the strategies that are used in IMR first are really to helping people understand what recovery means to them and what it would look like. And so you spend a lot of time at the beginning talking about goals, setting those goals with consumers, and monitoring those goals throughout so we can see what kind of progress are people making. And there are different modules that cover different topics. And the provider will teach the curriculum using different evidence-based strategies. So motivational strategies, encouraging people to make progress, reminding them about their goals, connecting that learning, breaking things down into smaller steps. So how do you teach things to people that they can learn and integrate better? And using some cognitive behavioral strategies like role playing to help people practice those strategies. And then you have home assignments so people can do them in the real world. And you involve significant others. And so this is just kind of a quick overview, but if you missed that session, you can go back to the website and see it again. And there are specific tools for you. So SAMHSA had a huge project several years ago to develop toolkits. And IMR is one of those specific toolkits that's free to you. You can download it and it has those materials for yourself as the provider and also handouts and things you can use with the people you're working with. So that was our first one. And it's a nice kind of core one to start with because I think that it helps us remember the importance of personalizing recovery and what that means for the person and what skills and knowledge do they need to go forward. Oops, I skipped one. Okay, the second one we did with Emily Treichler was on collaborative decision making. And she reinforced that this idea is, it's more about incorporating key elements of how you work together with clients rather than following specific step-by-step guides. So where IMR is a curriculum, and it can be used flexibly, but it is a curriculum with certain modules, this is more a way of thinking about how do we work with our clients. And those key elements are around setting recovery goals together, making sure we provide meaningful choice over what is being done in our treatment and how that's happening, really empowering clients or the people we're working with to speak up and be an active part of their treatment. And that it is really a two-way information exchange where people can really understand what the different options are in their treatment and kind of weighing out the pros and cons of that. And making sure that those choices are based on the person's goals, values, and preferences. And so this is really a process that we can do in every aspect of our treatment. So that was our second session. The third session was around ACT or ACT and supportive housing. And I think of ACT as really providing a nice structure for integrating a variety of evidence-based practices. all kinds of services can be done through this ACT structure. And that is the multidisciplinary team. So we have psychiatry, nursing, psychology, social work, peer providers, employment specialists, sometimes family specialists. You have a variety of different people who work together, and they provide that assertive outreach and intensive support in the community for people with more severe problems in daily living, for example. And it focuses on those everyday needs and being there in crisis. And supportive housing is one of those key services. And Leah Hicks is a consultant who was with us and talked about how those can often go together. So we can see supportive housing programs separate from ACT, but it's really nice when they go together, because that supportive housing piece is really important for people who have had a lot of instability in where they live, a series of episodes of homelessness, or being in and out of the hospital or the jails or the emergency system. So they really go well together. And the idea in supportive housing is to find affordable housing and helping people have their own lease, so they become tenants, and provides flexible and voluntary services to support them in those places of where they choose to live. And also coordinating among providers and connecting them with the community. Our fourth session was on supported employment. And so Marina and Amy came to talk to us about how to help people with severe mental illness find work in regular competitive employment jobs in the community. And so they talked about the importance of helping develop new jobs. There's a rapid job search, and that's the idea that people don't need a lot of pre-vocational training. It used to be we thought people had to go through workshops and then get a lot of training before we could place them in real jobs in the community. And this model basically turns that on its head and says that if people want to work, we help them find a job and we support them in that setting. And we need to integrate that employment service with mental health. And we don't exclude people because they have hallucinations or because they have substance use or other problems. We try to work with what they bring to the table and build on their strengths and find a good placement for them and support them in those places. And the fifth one, Angie Rollins came a couple of weeks ago to talk to you about integrated dual disorders treatment. And this screen looks very complicated because integrated dual disorders treatment is really an approach that is addressing substance use problems in people who have severe mental illness. They often go together, and the old way of doing things was to have these separate streams. And often we would say to people, you have to get your substance use handled before we can deal with your mental health issues. And the substance use people would say, no, you have to get your mental health under control before we can deal with your substance use. And so this really recognizes that those should be treated together consistently. And it also adds some other things with it. And Angie was really great about narrowing it down to 3 key things. And so the basic ideas are to think about where people are in their stage of change. Do they even recognize they have a problem yet? Are they starting to see that they want to change? And you do different things based on those stages of change. And that'll come back later in this talk too. The second point is thinking about, this is a long-term approach. And for many of our services for people with severe mental illness, these are long-term relationships that we're investing in and they're investing in with us. And so being patient, being able to handle the ups and downs over time is important. And then in our integrated approaches, really trying to encourage and provide support so that people can get a variety of different services to support their recoveries from substance use. And so, as I mentioned earlier, treatment gets you into wellness, so you can't expect people to be well before you start providing services. So that's my brief recap of what has happened for the last 5 sessions to sort of get us on the same page. And I wanted to shift now to what are some of the core concepts that unite these different practices. And I think the biggest point here is to think about person-centered care. And the World Health Organization describes that as really empowering people to take charge of their own health rather than being passive recipients. And the origins really come out of Carl Rogers' approach to therapy. And he really emphasized that psychotherapists should appreciate the person's experience without judgment, that we come to that relationship with unconditional positive regard. And it's that acceptance of a person that really helps them move in therapy and to get better. And so really it comes through Carl Rogers' work. In the 1970s, the medical model started shifting to more of a biopsychosocial approach, and George Engel really brought that to life in terms of a broader perspective of seeing the patient that you're working with beyond the diagnosis, that it's a person who has all of these other concerns. And we know in our work in mental health, we've always had to look at all those things that come together. But that was really the movement in the 1970s. And then in the 90s, the chronic care model became really popular in medicine. And that was the recognition that people live with medical conditions outside of the medical office. And so if you're seeing them in your office, whether you're a therapist or a social worker or a primary care doctor, you only have that little bit of time with them. But the rest of their lives are out in the community, in their own homes, with the people they work with. And they have to manage whatever illness or condition that they have in those settings and over the long haul, so that we need to really partner with them and involve those community supports that can make that happen. And then in 2001, the Institute of Medicine made person-centered care a defining element of quality of care, that it was one of their 6 pillars to look at quality. And now most health policies really include these ideas. A lot of our work in recovery-oriented care, in the mental health side, and all health policies really talk about that person-centered care as being key. So what does person-centered care look like? And I think even though this little image comes from primary care, it's the same for us in our work with people with severe mental illness. But person-centered care first starts with the person. So we need to know the individual needs, desires, who this person is as a person. And we're not treating a disease or a disorder, we're treating a person. And it involves a full partnership with healthcare providers in promoting and maintaining health. And that person is centered in a larger community. They have family, they have culture, cultural backgrounds, and different connections that make them who they are as a person. And underneath all of that, we provide education and support to help them stand up in the middle and be in the middle of that care. Another view is from the Health Foundation in the UK, and there's a link. They have a nice document on person-centered care that is really nice. And they talk about how kind of at the base, we need to treat all the people we work with dignity and respect, and think about how would we want to be treated if we were in a treatment setting ourselves. And so that kind of is the base of person-centered care. And person-centered care should be coordinated. And we'll talk through each of these and how they fit with the evidence-based practices. Care should be personalized. And these things could actually happen without too much of the client's input, that we could treat people respectfully, we could coordinate their care on their behalf, we could individualize it to them if we know enough about them. But this third part, well, it's the fourth part, but the third part of care itself is that it should be enabling. And what they mean by that is that it's a partnership. It's a new kind of relationship where we partner with the person and we support them in developing the knowledge, the skills, and the confidence to fully participate. And so we can't do person-centered care without the person being an active part of that. So how does that happen in our evidence-based practices? One, in all of our practices, we need to get to know our clients, patients, consumers as people first. These are people who have interests and goals beyond the treatment setting that they are in. And so in our evidence-based practices, collaborative decision-making and IMR both have explicit strategies for developing those relationships and for helping people think about meaningful goals to define what they want and need in treatment and your relationship with them. And IMR in particular, in terms of a manual with tools, does have handouts for you as clinicians, for you to think about what kinds of questions might you ask people to really get to know them and understand their culture and background, their family, their community, what's important to them. So it has some specific tools for doing that. And then the other evidence-based practices that we talked about all provide services to help them meet those goals. And there are other evidence-based practices that we haven't covered in this series, but these are some of the basic ones that people talk about wanting to be able to live independently in their own places. They want to be able to have a job. And many of our people that we work with have substance use problems that interfere with those goals. And so treating that is really critical. But there are other practices that we might do with the people we work with once we know who they are as people and what it is they need. I think a second theme, we need to recognize that recovery needs are similar for all of us. And I wanted you to take a moment and think about the last time you were recovering from something. And if you feel like sharing, not what you were recovering from, but maybe what was it that you needed? And so think about a time, maybe you've been struggling with a chronic illness, or after an accident, after a divorce, or losing a loved one, or even happy, big stressors in your life, like moving to a new job or a house. What was one thing that you really need or needed to help you recover from that big stress. And so if you want to take a minute to write in an idea or two in chat. Time off work, so having some space from other responsibilities, having patience, yeah. Silence, yeah. Emotional support, that's a big one. Yeah, trusted, non-judgmental support, social contact, emotional support. Yeah, lots of support. When I started doing work with the illness management and recovery program, yep, basic needs, good. Susan Gingrich did a lot of the training. And one thing that she said that really stuck with me is that we all need motivation to get better. We have to have hope, something we can look forward to, something that is really important to us. And we need to have basic information. What is this illness or this thing I'm dealing with? What can I expect? What is it going to look like? We all need skills to get through that time, and supports. And a lot of you really focused on that aspect of it, having social support, people to be there for you, having all of those needs met. And we'll come back to some of this a little bit later. But the way that we do it needs to be personalized. So a lot of people talked about support, but maybe in different ways, maybe from family, or maybe to process the experience, or maybe advocacy. So we need to be personalized in how we do those things. And we can do that based on the person's goals, their strengths, their needs, their interests. That should really drive how we personalize that. So let's see. Okay. Oh. Okay. So that sort of covers the first two elements. We're treating people as people. We're personalizing their care and all of these evidence-based practices. Another critical one is that all of the care is coordinated. And more than coordinated, we actually integrate it in most of these practices where you're doing the care together. So ACT or ACT is an excellent structure for doing that, because it brings all those disciplines together, working together. ACT teams usually start with a morning meeting to coordinate their care and services. And some ACT teams will do a brief meeting at the end of the day to kind of wrap it up and bring it all back together. That way everyone's on the same page of what the people need, what they're getting, how we're working together. Supportive housing, those needs for services are integrated with the housing needs. If this person is going to live independently in this place, what is it they need to be successful, and really integrating those needs. Same with supported employment. We have a vocational specialist on a mental health team, ideally, that's they're positioned right in there, and they're working together to make sure that the employment and the mental health aspects are being handled. And of course, integrated dual disorders, that's part of the title. We're integrating both mental health and substance use problems in the same place at the same time together. So really coordinating and integrating is a key theme across all of these practices. And care is enabling. So partnering with people. So another theme, by enabling people, we're treating them as partners, and keeping in mind that autonomy and having a sense of control in our lives are fundamental human needs. And so the person's choice is really critical in each of these evidence-based practices. So where they live, what type of job they want, what motivation is driving them to engage in substance use treatment. It's their choice that really drives that. So we need to treat them as partners. And by supporting that choice, it allows people to trust us and allows our relationship to develop. So it's really critical for that. And similar, but a little bit different, another aspect of enabling people is really ensuring that they have the information, skills, and confidence to be partners with us. And one of the things I love about IMR is it really specifically identifies strategies and tools that you can use to teach a variety of topics. So people can learn about different aspects of mental illnesses that they might be struggling with. They can learn about coping with symptoms. They can learn ideas about how to get social support. So each of those modules has specific tools and strategies to help give them the skills and confidence they need. Collaborative decision making, we help them learn how to make decisions with us and with other providers as well. And so they can make better decisions with their doctors or with their primary care providers or other places where decisions need to be made. With ACT and supported housing, we're helping people learn skills in the community, living in a place with support as they're doing that. We help them with budgets, shopping for groceries, whatever it takes to be successful. We're teaching those skills in the community in those evidence-based practices. Supported employment. We don't do pre-vocational training. Instead, we really help try to place a person in a job that's of interest to them and support the person in that setting. And with integrated dual disorders, we're doing a lot of skill building in the active treatment phases and the response or relapse prevention phase. That's when we're working more on those skills. And all of these approaches really try to coordinate that placement, whether you're in the community or in a new job, with learning those skills and providing active ongoing supports. And so that's how these evidence-based practices really support that. And then going back to that other picture or image of person-centered care, we need to think about the context of the person and that care. And all of these evidence-based practices focus on being in a community and part of that community as well. So we can do IMR or collaborative decision-making or IDDT strategies anywhere. So you might be doing, I think in my first session, I talked about someone talking about doing IMR on a basketball court with someone because they couldn't sit down and focus on handouts, but they could talk about the ideas while they were doing something else. So you can do these things in the community. And ACT, supported housing, supported employment are exclusively done in those settings. And all of our practices really focus on functioning and community functioning. So how do we help people live fulfilling lives in the community rather than in hospitals? And that's how ACT came about, or rather than in group homes, so the supportive housing, and rather than in sheltered workshops, people are in real jobs. And all of them really emphasize natural supports and working with members of the community who can support the person. So how do we do all this? You may be doing a lot of these things already, but if there are some changes you want to make, or you want to help your clients make changes, these same change strategies can work for ourselves as well as the people we work with, and as well as our organizations. So you might think about administrators or supervisors and how you might work with them. So first, I want us to think about going back to some of the basics. And people who know me, I talk about self-determination theory all the time. It's my favorite theory. But it's really about intrinsic or internal motivation is such a powerful change agent. And really thinking about what it is that we each need to make some kind of a change. And they identify 3 components. Autonomy is the first one. So how much choice, control, or input do we have in making the change? And so if it comes from inside of us, we're much more likely to be committed to that change. So autonomy is really critical. The second one, belongingness. DC and Ryan really talked about it as relatedness, but some people use different terms here: connection, belonging, relatedness. But it's that idea that we need to be connected to a sense of purpose or meaning. And that may look different for different people. For some people, it's a spiritual, bigger picture. For other people, it may also be their family or their art, some kind of thing that is important that makes us want to get out of bed in the mornings. And the third area is a need for competence, that we all need to feel capable of doing things and having the right information and skills to feel confident. And we also need the right amount of challenge or difficulty to engage in a change. So if it's too easy, we're bored, we disconnect. If it's too hard, then it becomes overwhelming and we might disconnect for that reason. So really thinking about the right level of change so that people feel confident. Okay, trans-theoretical stages of change. And I know Angie talked about this a lot in the IDT talk. But this is really applicable across all kinds of change. And it's the idea that we need to consider where people are in thinking about their change and intervene appropriately. Oh, my goodness. Okay. In the third area, goal setting theory. And this comes from organizational literature, but Locke and Latham are 2 people who worked on this independently and then came together later. And they really identified how having specific and challenging goals, the right amount of challenge, along with appropriate feedback leads to the best performance. And they also emphasize how commitment to the goal is important. And that kind of goes back to that autonomy and control. How much did we commit to that? So some of the questions that came up throughout the series are dealing with resistant clients or maybe other coworkers who are resistant to change. How do we do that if we encounter that? Okay. The first thing, recognize that change is difficult for all of us. So the person is not necessarily being a stick in the mud. Change is hard. And so recognizing it's difficult. Roll with it. I love that phrase. It comes from motivational interviewing and thinking about when you come up against some change, if you press back or fight back against it, you're not going to get anywhere. So you need to just accept it, roll with it. Measure it. If people are trying to make changes, have you set with them SMART goals, specific, measurable? We talked about that in the first session, and Emily talked about it a little bit in the second session. Are the goals clear, defined? Are they getting feedback on their progress? If you can see you're making progress, that can motivate you to keep changing. Check your ABCs. Someone's resistant to change. Whose idea was it really? Is it their change they want to make? How important is the goal to that person? The belonging aspect of it. Does it connect with a sense of purpose or meaning for that person? Are they competent to do it? Do they have the skills? Do they have the confidence and the supports in place? And what stage of change are they? Are we doing the right things at the right time? And so going back to that, you can spend a little bit more time on this going back to the session from Angie, but if people are not even recognizing it's a problem, that pre-contemplation stage, we shouldn't be working on the skills building yet or referring them to certain treatments, but really trying to build that relationship, assess what's going on, provide practical help. And then when they start to prepare and think about change, then you start doing more active things. And it's not until they're ready to take action that we do a lot more of that active stuff. So when you sense that resistance, go back to those ideas and think about where could we change. Another thing that comes up with evidence-based practices is this idea, I can't do it all, or our team can't do this whole model to fidelity. And some of the specific things that have come up recently are the staffing crisis. It's hard to find and keep people, and the mass resignation of the COVID era has made it really difficult to have enough people help us and work with us. So we might not have the resources. So clicking is not good today. So my first recommendation, do the best you can with what you have. And it helps to really focus on the essentials. So going back to what we talked about today, you can practice those aspects of person-centered care that go across all the evidence-based practices. Get to know the people you're working with as people, what drives them, what's important to them. Personalize your services, coordinate or integrate them as much as you can. Oh. Emily has your hand up.
No, I'm good. Hit the wrong button.
Oh, okay, sorry. Enable people by treating them as partners and making sure they have the skills and information, and help people be in the community and part of it too. So even if you don't have a full structured ACT team or supported employment team, these are some of the things you can do. Brainstorm with other colleagues. And we did this in the psychology department recently because we are having staffing crisis as well. How do we focus on our core mission? What can we take off our plates to make room for this? Work with other people. Get support. Look for trusted peers or informal supervision groups, peer feedback, and seek out a trusted senior member in your organization. So can someone help provide a little supervision, do some job shadowing, give you some feedback? All of these things might help you do parts of the evidence-based practices that you can do. All right, so what comes next? This is really sad for me that this is our last session today. All of the presentations will be available on the Southeast MHTTC website, and we'll have downloadable files, and we'll have a summary tool for you as well. But we also want to hear from you. What else would be helpful? And so you can let us know. You can email me or Emily and Stephanie and Hannah to let people know what is it you'd like to see. And I would just, oops, I was gonna end my part before we do questions. If you would share in chat, what's one thing you want to apply from today's webinar? And then I will stop talking and see if there are specific questions you have for me too. Practice what we preach. Yeah, that's it is funny. I do a lot of work on burnout. Some of you might have seen, I did a series for this group last year on burnout, and a lot of the same things that we try to help our clients, or the people we work with, really apply to ourselves too. So going back and doing that. There, the model fidelity. Oh, great. Carlos is doing a lot of application from these. This is wonderful. I know in Angie's talk, she said, don't let the perfect be the enemy of the good. So even if you can't get to full fidelity, do what you can. Yeah, self-care to care for others, right? Self-awareness, supervision. Those are all critical things. Emily, I don't see my question. Oh, I don't see any specific questions, but if you guys have questions too for today, let me know.
Yeah, everyone just remember to put your questions in either the chat or the Q&A feature. And just to kick us off, Michelle, I did have a question. You talked a few slides ago about proposing a brainstorming session with colleagues. And I know that that can be something that makes a lot of people nervous to actually approach their colleagues or their supervisors for a brainstorming session and talk through some of these things. I was wondering how you propose those sorts of brainstorming sessions with your colleagues.
Yeah, well, I do recognize that your comfort level in trying something new in your organization depends on a lot of things, your personal risk taking, how long you've been in the position, the climate in your organization. So this may not work for everyone, but what I actually did was I emailed the chair of our department and said, we are all feeling stressed. We've lost several faculty to retirements or death, or in some cases, with the Great Resignation, people decided they didn't want to be in academia anymore. So the rest of us have had to take on all these extra things. So I asked if I could have 20 minutes, 25 minutes of a faculty meeting. And what I did was to say, as an psychology department, our main core mission is supporting our students, teaching, and research. We also have to do service too, but our main mission is teaching and research. How do we do that mission with what we have? What do we need to take off of our plate to make that happen? And then we got into small groups, and we identified one person as the note taker. I think I said, pick the person in your group that had the most pets or something random like that. And they came up with some ideas. And then we came back together as part of the big meeting, and each group said one idea that they thought would be helpful. And then I put them all together and gave that list back to the chair of our department. And they were things like cut our meetings in half, and to reduce some of the service needs to the most essential things. There were ideas about self-care. And so then that's kind of how I got it started. And then this month, when the faculty meeting was coming up and he asked if I wanted to follow that up, I said, well, the first thing I'd like you to do is make sure that the meeting is only 1 hour instead of 2. And he did that this time. So it's small steps, but I think that's a good way to think about it. It's bringing in other colleagues together to come up with ideas.
Awesome. Thanks so much. I don't see any other questions in the chat or in the Q&A feature. So just in the interest of time, if it's all right with you, we'll move on to the evaluation portion. But before we do you have any closing remarks to give for our Keeping It Practical series?
Yeah, just keep doing what you're doing. I'm really have been honored to be part of this series and to spend this time with you over the past several weeks, and have really valued and appreciated this time. So let me know if there are other things I can help with. So my contact information is in all the materials too. So I'll end it there, but thank you.
All right. Thank you so much, Michelle. And thank you to everybody for your participation in today's event. We value your feedback and invite you to evaluate today's event by completing a brief SAMHSA required survey that's available at the link presented on your screen. Completion of this survey will provide information to SAMHSA and assist us in planning future events and series like this one. You will also receive an evaluation link via email 30 days after today's workshop. Afterwards, you will automatically be directed to additional questions from the Southeast MHTTC regarding the impact of this event on your knowledge and skills. And there you will have the opportunity to download the certificate of attendance for your records. Please allow about 5 to 10 minutes for your, or 5 or 10 seconds for your browser to redirect you. Again, our center appreciates your participation and feedback. We hope you will join us for future events. Please visit our website to learn more. And that will conclude today's presentation and series. Thanks so much, everyone.